This video will discuss how to interpret MICs and how to read an antibiogram. The MIC, or minimum inhibitory concentration, is a term that is used by the microbiology lab. This refers to the lowest antibiotic concentration that inhibits the visible growth of bacteria. Knowing these values helps determine treatment options for your patient. It will tell you if the bug-drug combination is susceptible, intermediate, or resistant. If it is susceptible, the MIC will be less than the breakpoint that is defined by CLSI. If it is intermediate, the MIC will be equal to the breakpoint, and it's kind of on either side of the susceptible or resistance. If the MIC is greater than the breakpoint, then it will be defined as resistant, or R, and therapy with that agent is no longer recommended. To determine the MIC, it goes through a process known as broth dilution, which is now being used with multiple different technology advances that is not manually done. The organism is cultured and then it's placed into multiple test tubes. In each test tube, there are increasing drug concentrations. Once both the bacteria and the drug are in the test tube, they are observed for growth. If there is no visible growth, the MIC is labeled with that number. MIC values are numerically not representative of drug efficacy. These values are variable for each bug-drug combination. Just because ampicillin may report as 1 in susceptible or nitrofurantoin is reported as 8 in susceptible does not necessarily mean one is better than the other. Please refer to the interpretation of susceptible, intermediate, or resistant. Also remember that susceptible does not always mean 100% clinical response. These are in vitro studies that can tell you the likelihood that it will be susceptible or resistant. And remember, resistant does not mean a 0% response. There may be some colonies within the patient's bacterial load that is susceptible to the organism, but try to remember that if it is resistant, you should not use it. If it is susceptible, it's probably okay, as long as it gets to the site of action. Make sure you're considering those patient-specific factors such as renal function, volume of distribution, the area that you're trying to penetrate, and then the potential for resistance development if the patient is not adherent to therapy. For example, would nitrofurantoin achieve if nitrofurantoin achieves low concentrations in the blood, would this be a good choice for a bloodstream infection? And the correct answer would be no. Remember, you would want to select an agent that has high levels of concentration at the site of infection, not low levels. Here's an example of how a susceptibility report may display on an electronic medical record. You can see here we have the initial gram stain showing gram-positive cocci in clusters, the identification of the organism as Staphylococcus aureus, and then finally down here we have the sensitivities along with these MICs right here to tell you if the strain was resistant or sensitive to the organism. You can see that oxacillin is sensitive, but tetracycline is sensitive, but clindamycin up here is resistant. Therefore, clindamycin would not be a good choice to treat this Staphylococcus aureus. Next, we will discuss the antibiogram. The antibiogram is an annual report that provides a comprehensive listing of the susceptibility trends at a specific institution. These are usually created in-house and aid the clinician in the selection of the most appropriate agents for empiric antimicrobial therapy. It also provides a way for the health system to monitor resistance trends. These are usually located on the intranet at most institutions. The antibiogram is created each year and cannot be created until all the data points for that year are documented. Therefore, the antibiogram you refer to will always be from the year prior. Alright, so let's take a look at an antibiogram. Most antibiograms are set up very similar, with the different organisms split up by gram-negative and gram-positive, and these are listed in the leftmost column. Next, you have the number of isolates that they've isolated throughout the last year of those specific organisms. And then the top row shows the different antibiotics that were tested against these organisms. And you can see that some of these organisms or some of these areas are left blank, and that is just that either they didn't have enough isolates that were tested against that organism, or that organism doesn't have activity against that, that antibiotic doesn't have activity against that organism. Therefore, it wouldn't be appropriate to test it. So to read the table correctly, you have to follow the organism and the antibiotic and find where they meet. As you can see here, Pseudomonas aligned with Cipro shows that Pseudomonas was sensitive to ciprofloxacin 81% of the time. To determine the resistant rate, you just subtract that number from 100. Therefore, the resistant rate of ciprofloxacin to Pseudomonas was 100 minus 81, which would be 19% were resistant. I'll now go through a case to help you get a better understanding of how this applies to practice. Here we have a 36-year-old female who presents to your office with classic signs of a UTI. She states she has dysuria and increased frequency. She tells you that she rarely gets UTIs, but usually she takes ciprofloxacin. She's otherwise healthy, has no known drug allergies, and her urine dipstick is positive for leukocyte esterase and nitrates. In order to determine the best empiric therapy for this patient, you will need to assess your antibiogram. Remember, at this point you will not have a culture result, so you're going off your best guess treatment. The most common organism to cause UTIs is E. coli, so you would want to find that first in the left column. And then you'll scan through the antibiotics that were tested. You've got a combination here of oral and IV therapies. Once you've looked at your options, you'll find a few agents you would actually consider treating the patient with. For this example, I've selected cefazolin, which is an IV agent, but does have an oral equivalent called cephalexin or Keflex. Also selected ciprofloxacin, nitrofurantoin, and trimethoprim sulfamethoxazole. For this patient, you would just look at the top row labeled just E. coli. Because this patient is a previously healthy young woman, you'd have a very, very low suspicion that she has an extended spectrum beta-lactamase or an ESBL, which is a type of resistance mechanism. Here you can see that we have high susceptibility rates for cefazolin and nitrofurantoin, therefore making these better options than either ciprofloxacin or trimethoprim sulfamethoxazole. So you decided to prescribe nitrofurantoin and want to know what the resistant rate might be for E. coli. So to get this, remember you calculate it by subtracting from 100. So 100 minus the 97% susceptibility rate gives you a 3% resistance rate. This concludes the MIC and antibiogram video. Thank you for watching.